Okay, so I'm going to talk about thrombosed mechanical prosthetic valve management and what is our approach at Madras Medical Mission. So as you know that the valve disease is predominantly in India due to rheumatic heart disease. Though repair of the rheumatic valve is an option, it may not be very good because the mechanical valves are good for durability, but they once you have to put the mechanical valve, then you have to anticoagulate them with vitamin K anticoagulants. You cannot use, NOACs for this purpose. The most important thing is to maintain the prosthetic valve function and to avoid the thrombotic complication, and the INR should be between 2.5 and 3 in this scenario. Despite all the dedicated clinics, we still have a large number of patients who will present with stuck leaflets, and the valve thrombosis is high in the mitral and tricuspid as compared to the aortic position, and it ranges from maybe 1 to about 5%. In a tertiary referral center like ours, I get one a week, either referred directly or coming from another center. The guideline treatment consists of giving heparin infusion, thrombolysis, which can be low infusion, and redo surgery. Transcatheter manipulation of immobile lifeless can be pursued if patients are thrombolytic or surgically high risk as a bridge to surgery. Now, if you look at this paper, which was published in JACC, the Hatusha study, you can see the study cohort of 276 patients, but a lot of these patients had we had to be not recruited because they were not thrombolysis eligible. And there were a lot who had surgical. So only 2 out of 200 patients, ultimately only 214. That's 1/3 got excluded. And we had a final study population of 158. And if you really look at it, the success was defined in that study as documentation of complete improvement in bald hemodynamics, reduction in major diameters, area of thrombosis, and symptomatic improvement. But none of them had fluoroscopy and CT opening to be checked, because I feel if the CT doesn't show the leaflets are open, then we will be in trouble for the whole thing, because leaflet which is not fully open on a CT will again get into trouble and get restuck. And in this study, obviously, surgery had poorer outcomes as compared to the thrombolysis. And what was used was a slow infusion of TPA for the study. Now, what is the problem? The problem is you have a leaflet, which you usually buy leaflet valves in most of our practice, and the hinges get clots, or the lateral orifice gets a clot. And then what happens is the leaflet gets stuck. You can see on the top the picture live, and here is a cartoon which shows a stuck valve. And the stuck valve can have a clot on the left atrial side or the left ventricular side. And it also can come on the hinge. And what we are proposing here is that we put a wire and coronary balloon across, balloon dilate the hinge, so that what happens is that the leaflet gets unstuck and the clots gets released. Obviously, you have to protect the brain and other circuit with filters so that we don't get into trouble with embolization. And this is how a leaflet will come open after we open the valve out. Now, the research question here is that when you're doing this balloon, will the leaflet dislodge or avulse? Will there be a ring fracture? Or will the annulus deform or malfunction? And if there's a strong bond between clot and leaflet, will it force to release? Coronary and cerebral and other systemic embolism is the next issue. Now, this last number 5 can be easily done by a filter or thrombus aspiration or a transcatheter embolectomy, but the rest is not studied. So our research question started with an animal study or a bench study. Could you answer this problem? And this is the most important thing, because there's lack of information on these areas of what these leaflets are like, what are the sizes in between the leaflet and lateral. Now, how do you check to address this research lacunae? I can take brand new valves and see if they break during balloon dilatation. Unfortunately, they are not a mimic of in vivo scenario where the wear and tear at core body temperature over several years will make the valves a different valve than a new valve. So we can't study it in that way. An animal study has a problem because implanting the valve and waiting for the stuck valve after several years is not feasible. And you won't get an animal to survive that long to get this done. The closer in vivo scenario is to explant mechanical valves during resurgery in humans and then to see how it goes. And this is how you do. This is a 2-year, 4-month-old ATS valve which got stuck. We measure with calipers the interleaflet distance and the lateral orifice distance, and then get a balloon sizing for the valve. Remember, this is very important because you need to have a CT picture of most patients to be completely. Echo is a poor indicator of all this. Now, what we did was we bench tested this right either in the center with a balloon and in the lateral orifice with another balloon. So you can see both the pictures and the videos on the other side in the cath lab on a Sunday. And then we see that when you put on the central balloon and dilate, you can see as the pressure goes up, this is a 10 millimeter Mustang. Normally a 5 millimeter balloon is what you use. And at 12 atmospheres, you'll see that the leaflets start bending, and at a critical point of time, the leaflet you can see will fly away like this. And you can see in the last part of the picture how it flies away from the valve. So this is dangerous. So if you start doing high pressure with big balloons, you're going to land up with that sort of a problem, and the leaflet will fly away. Now, but it is interesting that when you do it on the lateral surface and not in the center, the leaflets just get broken into shreds. And this, again, you can see how we are checking in the bench what is happening. And clearly the leaflets gets broken into small shreds when we do this here. So the issue is that we need to have the correct size balloon. We need to have a CT to measure these things. And we started out of desperation in certain patients who were either thrombolysis who could not be given because of stroke or something, or who failed the thrombolysis. You should understand that thrombolysis is not completely safe. The success rates, even with the best low infusion 48 hours thrombolysis, is 85%. 5% will fail, and 10% will have bleeds in the brain, and there's a 5% mortality. So it's not a completely safe procedure if everybody says that's okay. And this was data on 39 stuck valve procedures, which we have done since 2020. And let me tell you, these are patients who are surgically rejected because of multiple surgeries in the past, or thrombolysis not eligible. So what we do is we puncture the atrial septum, just like you do a BMV. Then put the wire, INOE wire down. Then we take a deflectable Agili sheath, which is what we use like in TMBR and in electrophysiology testing, which can be deflected into the mitral valve. We protect both the brain carotid structures with bilateral 6 millimeter spider filters. We could also use the Boston Sentinel filter if you have the money. You could use that. That's also one thing, and you can go radial. We Doppler both upper vertebral, upper limb, and lower limb, and we also check the lactate levels before the procedure. And this is a cartoon of how we do the procedure. The catheter goes through the valve leaflets in the center. There's a coronary balloon, which is 5 or 4 millimeter with a wire. There's 2 cerebral filters here. And this is how the leaflet would be measured before to check on CT what is the size of the balloon in the middle and the lateral. And you can see it's a 4 to 5 millimeter balloon in the center and about 10 to 12 millimeter balloon on the lateral side. So we make the balloon size, and then we cross it in the center with the wire and with the directed, and we put a 5 millimeter balloon in the center. And you can see as the balloon goes up, the left atrial pressure will start suddenly going up because there's free MR, and the patients will develop usually pulmonary edema. Most of these are ventilated patients, so you can see the LA pressure going up, and you can see then the leaflets are getting open. So there's a complete release of the leaflet, and both the leaflets are moving well. And we measure the angles, and this is very important because the measuring of the angles is the most important thing that the leaflet. So you can see this leaflet has moved in systole to diastole and come back, but this leaflet has not in the pre-situation. But in the post, and you can see here that in the post, you can see both the leaflets are open, and then once you release the clot, then the leaflets come back to position, and the gradients drop. Remember, even one leaflet opening up will drop the gradient. So gradient is not a great indicator, because if the other leaflet is still stuck, you're going to get trouble with the whole problem. 30% of our patients will have debris in the brain caught on the filters or the sentinel. And so you cannot do this procedure without cerebral protection. We also look at Dopplers of both lower limb and upper limb just to check there's no embolism, and we look at the ECG to hope that there's no coronary embolism, and lactates for mesenteric artery. So these are the various valves we have checked. You have the Carbomedicus, the ATS-AP, St. Jude, all that sort of valves. I don't want to go through all that. But we first published our first paper of 6 patients in structural heart for the mechanical at the mitral position. And this was in 2020. Then we published the next 6 with aortic position in JSCI. And you can see the stuff. It's not necessarily clogged. And the final big paper we published in Circulation this year for patients with this problem. So this is the big paper in Circulation, which we have now published for patients who are not eligible for lysis and surgery. And this was a Petros. Petros is a short form for percutaneous release of stuck valves. We can do a primary in patients who have a contraindication for fibrinolysis, or who are not willing for fibrinolysis, or you have a rescue where there's a failed fibrinolysis or stroke during lysis. And we have followed these patients for 48 months. And these are the various leaflets. And what I conclude is that you have a 92% success in this. We had 2 deaths. One was a sudden death on follow-up at 1 year, and one was a death who had a vertebral stroke. And that was not protected with filters. The recurrence is there, but you can fix it either by reintervention or fibrinolysis. And a repeat Petros is performed in 2 patients. The most important thing is that the gradients are great at follow-up of 4.7 mean, and the ejection fractions are slowly getting better, and the right ventricular pressure and TAPSE are coming down. This is a Kaplan-Meier curve showing a very good success rate of 92% at 2 years. So what this showed was that mechanical valve thrombus has been clinically treated by surgery or fibrinolysis in high-risk surgical patients. What this adds is another method of releasing these patients if they are not candidates for either of these. This was a letter to editor which came from the Hattusha study primary investigators suggesting that thrombolysis should be preferred, and we agree with that because all centers cannot do all these complicated procedures. But what we need to show is that 1/3 of the patients on the Hattusha trial could not be included because they already had a stroke or a lysis failed, and that's what we said. And the filters only protect both this brain circulation, the carotid territory, but there are new epi-aortic filters coming in which could protect the whole circulation in this issue. So this is my conclusion. I hope this gives you an idea of what's happening in this area, which is new technology. And I think that today, last month, there's a JACC review on stuck valves, which has now made it a 2B indication to do this procedure. And it's part of the reference is our work, which we have done. So I'm happy to say that many centers in the US, Israel, Brazil, and India have started doing these procedures, which is an option. We're also running a randomized trial head-to-head, slow lysis versus a primary Petros. And we have recruited about 40 patients on this study in a single center. Let's see how it goes. Thank you very much. And if there are any questions, I'm happy to take.
Thank you, Dr. Ajit Mullasari. First question is, how do you decide that whether it is a real thrombus or it is a Banner's formation, particularly for the aortic valve?
That's very important. So the CT is mandatory. So you check the HSU units of the stuff which is sitting on the valve. Echo is no good for this. If the HSU units of the stuff behind the valve is less than 130, it is thrombus. If it's more than 240, it is pannus. If it's between that, it could be pannus or thrombus. Again, if it's a small pannus, there's no need to worry. We can still fix it. It will still open. But if it's a large pannus, it cannot be done, and they have to go for surgery.
Ajit, this is Dr. Tushar. I am a surgeon.
Yeah.
Any surgeon who has operated on stuck valves faces a dilemma whether to declot the valve or change the valve. And most of the times, surgeon doesn't want to take a chance and he changes them. How about the same argument being applied to your patients? One. And second, how many of these 30 patients were sent for surgery and why?
So let me be very clear. This is a preliminary study, and the approval from the ethics committee was for no. These patients had either 2 surgeries or 3 surgeries and clear surgical rejects, or 2. They had lysis failed, or had a clot or a thrombus having a stroke, and they could not be lysed. So these are the only group of patients we recruited. We are not talking about patients who are clear-cut surgical or clear-cut lysis. Those are not the patients included in the study. Number 2, I understand your concerns that as a surgeon, when you see it, sometimes it's so full of stuff. You sometimes remove it and change the valve completely, and you're now dealing. But here's a bailout procedure. We are talking about a patient whom you bail them out, and then you have a chance to do something later. You could do surgery later. You could do medical treatment follow-up, and you can delay a surgery for the future. So that's the plan.
How many patients were subjected to surgery out of these 30?
So none of the patients in this 39, because they are clearly surgical rejects, so they cannot go for surgery. So there was no question of surgery. But we have now a 151 patient registry in the hospital where we had 32 patients going for, but these are stable patients. That is a different subset of patients where the surgeon is comfortable doing them if they are not multiple surgery patients. And we have almost 100 plus patients who have been lysed, which is still our primary mode of treatment till we run the randomized trial and prove that either is effective or worse.
Have you tried in unileaflet valves, TTK
Yeah.
valve?
Yeah, the unileaflet valves have different. We have less patients on this study on unileaflet. We have only 3 out of 51. These, as you know, the Medtronic Hall was a common one which we used to see. They are really good valves, to be very honest. We see less thrombosis there in those patients. But you need only 1 balloon in the lateral orifice to open it up. And they do as well in the mitral position. Remember, in the aortic position, because the high flow situation, the procedure is not as successful as in the mitral. We got only a 70% success in the aortic position. Most of them are pannus because being high flow, when they present, it's usually hard pannus, which the surgeon has to get out of the whole thing.
Thank you.
Thank you.
Thank you, Dr. Ajit. A big round of applause for him.